All right, guys, welcome to the recorded version of the M&M for, I think, November 6th, something like that. I'm not sure. I think it's November 6th. Anyway, really quickly wanted to go over kind of what we're all about here as EMS coordinators, as your EMS coordinators, because we are here to go to bat for you. And believe me, we do go to bat for EMS in the healthcare system on pretty much a daily basis. So we're all very, very much invested in the EMS field and moving the EMS field forwards and giving EMS providers additional opportunities. We feel really, really, really strongly about that. So quality improvement is not the annoying guy looking over your shoulder telling you what to do. We're all here to better patient care and to improve how care is delivered to patients. So we're here to improve. The way in which we do that very often comes about from your ideas. So many of the ideas and solutions that we propose originated with one or several of you and or your team members. So we've got a lot of good, experienced folks in our division here at Bay State, but two heads are always better than one. There's always something to be learned from other people. It's really, really important to have a diverse and well-rounded group of people working on any project. So we welcome your input, and we basically see ourselves as facilitating solutions. So the answers are out there. We just need to ask the right questions and apply the right solutions to achieve our result. So that's kind of what we're here for. In doing so, in dealing with corrective actions or that sort of thing, we always approach it from this is an educational opportunity. So a just culture, some of you are probably familiar with a just culture. Some of you may not be. Just culture is the idea that you create an environment in which disclosing errors is acceptable and encouraged. And a big part of that is avoiding a blame culture. This is not helpful for anybody. Not helpful for anybody. Neither is a no blame culture. So we're not talking about no accountability. We're talking about a balance right here in the middle in which we learn from others' mistakes so we don't have to repeat the mistakes of other people. And most commonly, we look at a system perspective. So where could we have improved the system that would have avoided this issue? So again, the person, the individual, that's the last place you should be looking as the root of an issue. It's always look at the system. So just culture is a healthy balance. And so hopefully if you're one of the people in your organization that does clinical quality improvement, if you're the clinical coordinator, the ALS coordinator, or whatever you're called in your department, if you are improving things and making things better for patients, the best way to do that is through just culture principles. Yeah, so we'll kind of move on from there. If you're interested in just culture, you want to learn more about that, there's all sorts of great resources out there for just culture. You could search the hashtag FOAMED and then keyword just culture. There's all sorts of cool stuff out there. So this is an interesting case I wanted to talk about that came to Bay State. I actually have this incorrectly labeled as a 24-hour case. I don't think this was a 24-hour case, but in any case, it was a neurointerventional case. And so this patient received a mechanical thrombectomy. So they went in mechanically and pulled out this large clot. And so you can see a picture of the clot once it was removed right here. Obviously, that's removed. You can see the initial layer. You can see the difference here, just like you can in a heart. You can see that in the brain, there was a large blockage. Looks like right about here. I can't tell if that's a bend going off to that or if that's where the blockage is. In any case, there's a blockage in here, and none of this area is getting blood. The NIHSS score you can see is 18, so that's a really big stroke. That's a large vessel occlusion, or LVO stroke. Those types of strokes do not often, I shouldn't say do not often, but they often do not respond well to IV TPA. In other words, they're so big that IV TPA is not able to break them down and to dissolve the clot. And so you have to go in and mechanically pull this clot out or do some other procedures, but they all involve going inside there. So you're, there's arterial TPA, there's intrathrombus TPA, so all sorts of things. So this one got a mechanical thrombectomy. So they basically went in with like a corkscrew, like for your wine bottle, and pulled that clot out. So you can see last known well was at 8 a.m. Really, 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 I cannot emphasize enough how important it is to have that documented last known well. So it's important not only to document it, but to communicate and make sure the whole team got that information. Your reports are read. Many of you have received feedback from our stroke coordinator or from us on strokes. That's a big thing here at Bay State. We're working towards all sorts of cool stroke stuff here throughout the healthcare system. But it's really important that EMS has a documented last known well time. So in my experience in the field, I actually preferred that a family member could come along with the patient. So if I didn't know the answer to a question, or later on there's some other question that needed to be asked, that family member was right there with the patient. So I was very quick to try to make sure that somebody who knew the patient, knew the patient's history, was very familiar with the patient, would come along with me and with my partner and with the patient to the hospital to answer any farther questions that I may have not have thought to answer. So this particular patient was taken to Holyoke Medical Center by Action Ambulance. They did a good job of getting her to a stroke center. Holyoke Medical Center gave IV TPA 34 minutes after arrival. That's a really good time. Patient was transported after a CTA. It's very important that these patients get a CT and a CTA. So you can check for that large vessel occlusion, because if they're not doing that, they're probably not checking for a large vessel occlusion, and that's really bad. So they did that. They checked for a large vessel occlusion, started the IV TPA, and transported the patient, had the patient transferred to Bay State Medical Center, and the patient arrived in the cath lab at 11:11 a.m. Not particularly impressed with, I shouldn't say that. I was going to say I'm not particularly impressed with the time in the hospital, but here's the thing with these folks, these folks get a perfusion CT. And so what they do is they go in and they have some algorithms, and they can do an MRI, a functional MRI, I think it's a functional MRI, and evaluate this patient. So what they'll do is they'll look at the core area of infarct and compare that to the area of ischemia, or also known as penumbra. And if it meets certain criteria, they'll go in and remove that clot. So the idea is you have this ratio. So let's say this is the, let's say this is the brain here. I'm just going to draw it right here. So let's say this is your brain. I know it's funky shaped. I get it. I'm sorry. I'm not an artist. Oh, and I'm doing this with my mouse. Anyway, so this is your brain, and let's say you have this core area of infarct right there. And then you have this other area around it. Well, if the ratio of core infarct, meaning this is not salvageable, but this is salvageable, so it's not dead yet, is salvageable, they'll go in and pull that out all the way out to 24 hours. So that's where that comes in. That's why it's so few patients that meet this criteria, because there's a whole bunch of criteria for it. I think we've done, last time I heard, 3 24-hour cases. We do somewhere in the 30s or 40s for not 24 hours, but for neurointerventional, so mechanical thrombectomy, somewhere 30s to 40s. I can't remember what. So those are the patients that are large vessel occlusions, and that IVTPA is not likely to be helpful for. So that's how often this happens. So just be aware of that. I think it's very important for EMS providers to know. So 24 hours, that's a big window, and it's different, it's new. It came about as a result of the Dawn trial. If you want to read more about that trial, you can check that out. It's DAWN, because most of these patients are the ones that present in the morning after going to sleep normal, and they wake up and they have signs and symptoms of a stroke. So it's the Dawn trial. So you can check that out, read it. It was recently published. Interestingly enough, sorry, area of strokes is my area of passion. There are hospitals that have been doing this mechanical thrombectomy. I worked at a hospital, and when George Bush was still president, we were doing mechanical thrombectomies. I remember because George Bush visited the hospital, and his Secret Service folks came in, and the Men in Black and all this sorts of crazy stuff. But anyway, he visited the hospital. We were doing mechanical thrombectomy then. Some of the footage from those procedures was actually used in one of the ER episodes back when ER was still on TV. So it's new, but it's not new. So yeah, just be aware of that. All right, change goes to change, right? So it took a while to implement that change. Change is inevitable in healthcare. It happens every day, all the time. And we as healthcare providers need to ideally embrace it, but at least accept it. I love change. I get bored really easy, so I'm always interested in the next big thing. Like, all right, cool, we did that well. What can we do better? There's always something we can do better. What did we do better? What can we do better? And so that is not how everybody is. I've under no illusions that everybody likes change that much. And I think as I get older, I'll probably like change less and less. I already like change less than I used to. Hopefully, though, I retain some bit of embracing change, which Wook and I are very similar in this way. We both get bored easy. He's kind of an old dude, and he still embraces change. So I have hopes for me. Don't tell him I said that.
Technology accelerates at a relentless pace. Anything not moving forward is moving backward. The 2013 GS with the Lexus Inform app suite, one of the most connected information and communication technologies available in an automobile. The 2013 Lexus GS. There's no going back.
There's no going back. If you're not moving forwards, you're moving backwards. So change is inevitable. It's constant, but it sucks sometimes. It's really hard. It's a very emotional process. For a lot of people, a change is it elicits very strong emotions. And they vary from anxiety and confusion when they first realize, no, I'm tired of this crap. I don't want to change anymore. So they have this valley of anxiety and confusion maybe. And then they come up to, hopefully, sometimes people just get stuck there and they live there. But if you're going to be successful long term, you sort of tend to, not always, but tend to have this sort of peak of elation and relief. And you're like, oh my God, this is amazing. We could do this and this and this and this and this and this, and it'll even help with this. And the reality is it's going to address some of those things. It's probably not going to address all of those things, right? Shoot for the stars and shoot for the moon, you land among the stars. I don't know, some sort of philosophical thing like that. You sort of reach this slope of understanding and achieve a plateau of acceptance. I'm a graphical person. I should say I'm a visual person. So I like these graphs that really show stuff. Here's a super busy graph, but I like it. I think it's really accurate. And I see myself and I see how I've reacted sometimes to this. And I think we all can see and or think of a coworker who has reacted in some of these ways. But it's sort of the idea that you are going to face all sorts of emotions, and how you react to those emotions, how you handle those emotions can either lead to success or failure. So we want to be successful. So one of those things, I think a major one, is denial. So just stick your head in the sand like an ostrich and just ignore the change because this is the way we've always done it. It's not broke, don't fix it. It may be broke. It may just be that you didn't realize it was broke, or that I didn't realize it was broke. And if I didn't realize something was broke, I'm probably initially going to say, I don't know, that's unnecessary, and I'm just going to deny it. Or you're going to become disillusioned, aka burnt out, crispy. I think we all can think of people who are burnt out and or frustrated, and they say screw this and I'm done, or they just stick around and make everybody miserable. This is the one I frequently fall into. I fall into this one. I shouldn't say frequently. I hope it's not frequently. I'm pretty hard on myself. So I think it's more often than it should be. I fall into this. And I kind of see this to me as I get frustrated. I just want to do this and stop resisting. So stop trying to impede progress. Get out of the way and let's do this. I don't want to have a conversation about it. I just want to get stuff done. And that is not a great reaction. And people around you, people around me, are not going to respond well to that. So that's something when I sort of take some time to look at myself, this is where I can fall off the track. To be successful, you want to reach that part. So you're moving forwards and you kind of come to this acceptance and you successfully navigate this. And hopefully you help your friends and your colleagues and coworkers successfully navigate this. It's emotional, right? So stages of change, very similar to the stages of grief, right? So you can deny, get angry, try to bargain, you just get depressed, and then you're finally like, whatever, and you accept it. Hopefully, not whatever. Hopefully, it's like, heck yeah, this is awesome. And you accept it. The stages of grief, I think it fits well into this as an analogy. Case number 1, you're dispatched to a sweaty guy riding a bike, and it's never this guy. So, it's this guy. So, he's been riding a bike, a motorcycle, as it turns out, and you arrive on scene, and he's sort of rolling around on the ground in pain, writhing in pain, extreme amount of pain, apparently. So he speaks Spanish, and he's complaining of sudden onset of chest pain, breathing difficulty, and weakness. He's denying any drug use. His pain is mid-sternal, non-reproducible, and he's denying any other complaints. So I'm fine other than sudden onset chest pain, breathing difficulty, and weakness. So, just that. He speaks Spanish, and there's a language barrier. So it's not just, hey, by the way, I speak Spanish. Don't act like you're not impressed. There's a language barrier. So when there's a language barrier, you have to be even better with your assessment, right? Because it's difficult to communicate. And so the patient may not be able to tell you the intricate details of what is happening. So you have to be able to learn those things on your own. So what do you do next? Do you A, start a tickle fight? He's rolling around the ground after all. Acquire a 12 lead. Ask about prior medical history. Sometimes it's helpful to ask the same question again in a slightly different way. Sometimes you get a different answer that's helpful. Assess for JVD and lung sounds, maybe. Secure IV access or something else. I'm sure there's all sorts of things we could come up with that are options that we could do. But all of them should probably come after you acquire a 12 lead. So chest pain, difficulty breathing, weakness, all red flags. So let's do a 12 lead. And I'm being a bit dramatic. He wasn't rolling around on the ground like that, but he was writhing in pain per the narrative. So that was sort of the closest little excerpt I could find. But acquiring a 12 lead, right? So no matter what, we need to decide and determine whether or not this patient is having a STEMI. It's very, 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 very important that you send and or send a STEMI alert or activate the cath lab, that sort of thing, as early as possible. So especially if it's at nighttime or on days in which the cath lab team is not in house, it's very important to send an alert as early as possible so that they can meet you at the hospital. Because while you're riding lights and siren to the hospital, the cardiologist and the cath lab team and all those folks are also driving to the hospital, hopefully. And so it's very important that you give them as much heads up as possible. So the EMS provider found there was negative HEE&T, no cyanosis. There was no JBD, so check. Bilateral chest rise and fall, mid-sternal chest pain, 7 out of 10. It's not reproducible. Abdomen soft and non-tender, non-distended. Pelvis is intact. All extremities are intact. I think that's one word. CMS present in all extremities. Skin is pale, warm, and dry. So we established an 18 gauge IV in the left AC with a good flush, no issues. We gave 324 milligrams of aspirin by mouth. We gave 0.4 milligrams of nitroglycerin sublingual times 2. No effect on the patient's pain. First EKG showed hyperacute T waves and no STEMI criteria. Posterior showed the same. CMED report called in as an in STEMI. Upon the third EKG, great job doing serial EKGs. Great job doing serial EKGs. Very, very good to do that. We noticed some interesting things like anterior elevation with inferior depression. So that did end up being a STEMI, and patient went home with good cardiac function afterwards. So let's move on to case number 2. Case number 2, this is for the BLS providers out there. So you're a BLS crew and you're dispatched as third truck in for an MVC with multiple injuries. That's your dispatch information. You arrive on scene and you find a 20-year-old male. The narrative says that all but one occupant in the patient's vehicle self-extricated, and EMS was directed to the patient. EMS found the patient sitting on a guardrail nearby, conscious, alert, and oriented. Said that they were unrestrained. They admitted to being unrestrained, driver's side rear passenger. That car that they were riding in was T-boned, and there was approximately 6 inches of patient compartment intrusion. So that's the really, really, really big part. Like, we're not, mechanism of injury is non-specific and not sensitive for acute injury. So it's not predictive. It's not reliably predictive of injury acuity, and so that's why mechanism as a criteria, that's not really emphasized anymore. So, but mechanism, I think defining what really is high mechanism and what is not. So T-bone type collisions are really bad because you can see the front of the car, you've got a lot of room to absorb impact energy. Back of the car, a lot of room to absorb impact energy. Side of the car, very small amount of room to absorb the energy coming this way. So just a little bit of room here between the patient, or the occupant rather, of the vehicle and the bumper or hood of this car. So, you got your side curtain airbags, and those help from bouncing your head off, to keep from bouncing your head off the hood ornament of the other car. But it's still a small amount of room. In this case, there ended up being an estimated 6 inches of passenger compartment intrusion. So you can lose this whole area of the car, right? They're designed to just fall apart, absorb that energy. Same in the back, less so, but still same in the back. They're designed to fall apart. So it doesn't really matter what the front or back of the car looks like as much as was their passenger compartment intrusion. So that's where you really start to have some actually concerning mechanism, is when you start to have this passenger compartment intrusion, whether that's here or here. I'm sure we've all been to those calls where, you hit a tree and the car looks like, it's got this the tree is like right here in the car. now that I've got scribble marks all over that. So when the tree's in, sitting here, that's really bad, and typically you don't have good results for those folks. Anyway, T-bone type collision, you're familiar with it. Kinetic energy. Rick, during the live session, did a great job of talking about kinetic energy and whether mass time or velocity has the greatest effect on the energy that's delivered. So this is your energy. And the question is, mass or volume, which one has the greatest effect on energy? So if I increase the mass, is there an exponential increase in the energy? Or if I increase the velocity, is there an exponential increase in the energy? And since velocity is squared, velocity has the biggest impact. So mass is obviously still an effect, but velocity is the biggest impact on this velocity. So really fast vehicle collisions are the most concerning. Those of you who are firearms enthusiasts, I just moved up here from South Carolina, and in the South, we're definitely guns are pretty common down there, and so you have this. I like to make the comparison between a rifle round and a pistol round. And so the pistol rounds, let's say a 45, the 45 bullet is actually larger diameter than many rifle rounds, but the velocity is far less. And so you have a rifle round, even something like an AR-15, the bullet diameter on an AR-15 is comparable to a 22, so which is a very small bullet, but it's moving very, very, very fast. So speed is a big part of determining mechanism of injury in collisions, more so than size or mass when you start to think about these injuries. So injuries to the patients, you kind of expect to see unilateral injuries. So if I got hit on the left side, I would expect to see some injuries on the left side. So maybe a left hip fracture, some lacerations, maybe a broken left arm, that sort of thing. If I bounce my head off the hood, I'm going to have some obvious external injuries on the side of my head. Internal injuries, though, are actually the most concerning. So musculoskeletal injuries, we can fix those. Vasculature and brain, so neurons, those are the ones that leave you with really, really terrible injuries. And right now in the NFL, there's an emphasis on head injuries and the impacts, repeated impacts to football players' heads and the diffuse axonal injuries that creates. So you have the brain is kind of like jello, so it sloshes around inside the head there, and as it does so, it stretches and contracts. But as it stretches, it can have microscopic damage. So you can have those neurons, the dendrites, and those neurojunctions get pulled apart, and you may not see immediate signs on the head CT. You may not see a big bleed, but there's still catastrophic injury. So EMS, we always talk about coup contra coup. So not only will you have injury on the impact side, but you'll also have injury on the other side as it sloshing around happens. But we kind of know about that one. But the biggest, arguably, some of the bigger concerns are this diffuse injury that happens to the head and to the neurons. Inside the torso, or the core, you have lots of large blood vessels, both venous and arterial. And you see there's a ligament here in the aortic arch, and it tends to cause tears with front slight lateral impacts. So you have this heart kind of goes forwards, and it kind of like You may ever used a cheese slicer. It's like a wire, right, that cuts through the cheese, and it's kind of the same thing. So you can have tears there, and you can have a AAA, right? Um, Ascending aortic aneurysm. Um, and so those are really bad because obviously you can bleed out really quick. It's just, the main pipe coming out of the heart. And if you cut a hole in it or cut it in half, even, it's bad news. Um, forget the golden hour for a lot of those if it's completely transected. So um, that's a big concern. You have neck injuries, right? So spinal cord injuries. And it's very important to note that there are a lot of spinous processes on, let me flip back to this page, on your neck. So I'm sure you've had the same same experience, but I've had people tell me, "Oh, I broke my neck," and da, da, da. "Oh, it's a good thing I put them on a backboard, man. I had a broke neck." Okay, well, hold on. When you say a broken neck, are we talking about one of these guys breaking off? Because if so, that's not a surgical thing. It's not typically, I should say, not a surgical thing. It's not really going to be a big deal. So you have these spinous processes here, and they can break off, and it doesn't endanger typically the spinal cord. Um, and so those are things to keep in mind, right? So you have those types of injuries in the neck, in the back. Then you can have crush injuries that do start to have some cord impacts. And then of course lungs, right? So diffuse lung injuries, you can pop a lung. Um, kind of like a paper bag. You have that front impact, if it's a front impact. In this case, it wasn't, but you have that front impact, occludes the airway, then the chest gets compressed, and you pop a lung. I've had 3 spontaneous pneumothoraxes, and I've had 3 chest tubes. And man, that is, I don't like my lungs. My lungs and I don't get along. The chest tubes are painful. But anyway, I digress. Pelvis injuries. These are devastating. You guys all know that, right? So you can have pelvic girdle injuries. My dad, a few months ago, this past summer, fell out of a hot air balloon. It's a long story. Sometime we can talk about it if you want to. But anyway, he fell out of a hot air balloon, and luckily he landed on his feet, but he was high enough that he had all sorts of injuries, crushed pelvis, open book pelvic fracture, that sort of thing. Lots of bleeding can happen. Lots and lots of bleeding, and you won't even notice it until it's a really big problem if you're not really closely looking at your patient. So abdominal injuries, lots of things in the abdomen that bleed. And if it's not bleeding, it's popping open and spilling all sorts of nastiness into the gut. So we've all heard the golden hour. The golden hour is not actually based on science. The golden hour was a marketing tool to help build regional trauma systems. And it was a simple way of communicating to the public that trauma injuries, major trauma injuries, are time sensitive. If you look at death after trauma, you have 3 peaks. So you have it kind of looks like that. Those are my 3 peaks. So this is within minutes after the injury, and that's from major organs, popping open, your spleen, your liver, AAA, aorta, that sort of thing. Several hours later, that's from your slow bleeds, and then several days later, and that's from these guys right here. That's from sepsis and those sorts of things. So when you pop things open and then you get infections and nastiness and all that sort of stuff. So you sort of have a distribution across 3 peaks of death after major injury. So liver, spleen, those are very vascular organs, pretty common for those to have lacerations, may or may not be life-threatening. And those happen from blunt force, which this would be a blunt force trauma, right? Lateral compression, you notice they're on the sides of the body. So as you break ribs and or impact and crush things on the side, they collapse on top of these vascular organs and bleeding happens. You can also have shearing. We talked about that earlier. All sorts of bad stuff can happen in the abdomen. Abdomen is one of a million things. Oh, to touch on this, we've got the new pain management options coming out. Really excited about that. But those are not to replace. The idea is not that we're trying to replace acute pain management options like fentanyl and morphine and hopefully eventually ketamine, those sorts of things. Those are not replacements. Tylenol, ibuprofen, they're not replacements. Toradol is good stuff, but it's not a replacement for narcotics when used appropriately. And don't let people tell you that we shouldn't give abdominal pain patients narcotics if appropriate. Okay? You don't have you don't have things covered up from abdominal pain management, right? So you may not care about the pain as much. You're still going to feel the pain. And these patients are going to get a CT. They're going to get an abdominal CT. So whether or not you can palpate and feel an injury, it doesn't matter so much in today's they're going to get a CT scan environment. So it's not a good reason to not appropriately treat your patient's pain. All right. So, patient stated he hit his head on the window, but denies loss of consciousness. He doesn't have any C-spine palpation. Denies any difficulty getting out of the vehicle. Um, he's talking in complete sentences. No cyanosis. No accessory muscle use. No posture. Good, great, pertinent negative documentation. So, looks pretty good, right? It's patient seems fine. You know, we've been to these calls before, but let's think back to how fast was the patient going. High rate of speed. So we don't know, but high rate of speed. And I know it's always just sort of a guesstimate, right? What was the speed limit here? Okay, we're going to guess that. But high rate of speed. So what do we remember about speed? Speed in that um, formula for kinetic energy measurement, speed is the exponential component there. So of course something's going to happen, right? Because it's an M&M. That's not true. You know, we both we try to cover good things and opportunities. So um, they did note a 3/4 inch laceration on the patient's left eyebrow. So if you sit on the left side, you know it's not unexpected that you're going to have some external injuries right on that left side. Um, so that's a clue, right? If you didn't know where he was in the car, that's a clue. He's now though starts to talk about pain all over, and the worst of it, it's in my chest. Awesome. All right, that's concerning. So assessment of lung sounds. Good job assessing lung sounds. We noticed some diminished lung sounds on the left side with the anterior posterior auscultation. It hurts to breathe, and I can tell you when I had a pneumothorax, it hurt to breathe. Holy crap, it was painful to breathe. I was doing guarding, so I wasn't taking a deep breath, and I wasn't letting it all out. As long as I stayed in the middle, it was less painful. And so automatically, as you start to breathe more shallow, your rate will likely increase. Um, so we're noticing a trend here, right? So the patient is trending towards sick from initial not sick. Now we're trending towards sick. So that continuous assessment of your patient. That's the benefit in EMS is that we're typically with one, maybe two patients. Sometimes there are more, but typically one patient, and so we can keep a really close eye and identify trends early if we're doing a good job of assessing the patient. So treatments for this patient that we did a C-collar, requested ALS, did reassessments. Patients now, they could say posturing for ease of breathing during transport. So I would interpret this as the patient is moving around and having a hard time getting comfortable. And so that can not only be a sign of pain, but it can also be a sign of what else? Hypoxia. Yeah, so we all know that, right? Your body, you don't want to lay down when you can't breathe. You want to sit up, you want to stand up. Um, so they set the patient straight up to help with ease of work or breathing. Good job. That's the other thing when you're talking about spinal motion restriction, the big idea there is that you make them comfortable and their body will naturally reduce movement to the spinal column. And so It's important that we try to make these patients as comfortable as possible, which is another great reason to manage their pain appropriately with medications, um, so they can hold more still and minimize any subsequent injury, which is very unlikely, by the way. You either injure your spine in the beginning or you don't. Um, so assess vital signs, SpO2, 92% on room air. Now, this guy was a young, healthy person. So 92% on room air is concerning, right? Now, the other thing I like to point out here is people will talk about, well, I don't really trust that number. Okay. Why? I hate the treat the patient, not the monitor saying. I hate that saying. I understand what the saying is, but I think too many times people take it out of context and they use it to ignore important signs. So, what's really important to do here is to look at not just this number. So, I'm not just concerned with this number. I want to look at the pleth waveform, right? So, I want to look at the waveform on the pulse ox reading. So, I want to look at that graphical representation of the pulse wave, of that arterial wave as it comes through wherever you have that pulse ox sensor placed. If it's a nice, pretty line, a nice, pretty tracing with bumps, right? I know it's terrible. I'm sorry. Um, Nice bumps that are associated with each of my QRS complexes. And I'm not even going to try to draw QRS complexes with the mouse here, but you get the idea. This is a graphical representation of a palpated pulse. So if I have a SAT 92% on room air and my pulse ox tracing looks like this, I am trusting it. I'm trusting it. If I have a pulse ox tracing that looks like this, I'm not trusting it because this is not a good sensing waveform, right? I don't trust this because I don't know if it's accurate. I don't have good sensing. I don't have nice clear waveform. And so I'm not trusting that 92%. I'm probably going to say in this case that the patient's SAT is at least 92%, but maybe more. And I'm not going to trust that. So that's where you would want to look at the patient, right? If you don't have a clear tracing, you want to really look at the patient that much more closely for signs and symptoms of hypoxia. So I like to say, instead of treat the patient, not the monitor, treat your patient with the help of the monitor and all the other tools that you have at your disposal. So just like a stethoscope, just like a blood pressure cuff, just like a pen light, just like your eyes, ears, all your senses are helping you treat this patient. Think of the monitor as just another tool. And the more you know about the tool that you're using, the more you can trust it or know when you should disregard some of its measurements. So don't treat the patient without the monitor because if you're a paramedic, don't treat the patient without the monitor because you're just throwing a tool out that can be helpful. Treat the patient with the help of the monitor. So trending. So patient plus 11 minutes, 108 over 60, respiratory rate 24, a little bit elevated, right? He may be, maybe his adrenaline's going, but you look at his pulse rate, 66. So maybe his, I don't know. His respiratory rate's a bit elevated. GCS 15, SATin 92%. Oh, okay. So we are concerned. We already assessed the lung sounds. Great job doing that. So we already know that we're concerned about potential pneumo or hemothoraxes here. So we're already aware of that, and we're already concerned about that, and we're just getting more concerned as we see things change. So put them on 6 liters of nasal cannula. Blood pressure doesn't change much. Respiratory rate comes down a bit. Pulse comes down just a tiny little bit. It's essentially the same, but we get 99% on 6 liters nasal cannula. So great job there. You don't want to peg them out at 100% because then they're off the scale and you get a hyperoxic state, and that's not great. In this call, no ALS was available, so they did 6 liters nasal cannula, got it to 99%. Patient did state there was some relief. Left side lung sounds remain slightly diminished upon arrival. So patient did have, I believe, a pneumothorax. So Point of entry criteria. Let's evaluate this call based with our Massachusetts state point of entry criteria. Perform primary survey. So ABC, uncontrolled airway, cardiopulmonary arrest? No. If they had, then this is immediately life-threatening, and you go to the closest hospital. But they didn't have this, so you go farther down. You go in. No. Does the patient then have other criteria? So physiologic criteria, GCS, is it less than 14 in this adult patient? Respiratory rate greater than 29 or less than 10, or otherwise out of range for their age appropriate measurements. And is the systolic blood pressure less than 90 for this adult patient? It's not. So no. Anatomic criteria. None of these fit. We don't talk about, I don't think we talked about whether or not the pelvis was stable yet. But he's walking around, so probably stable. Paralysis, not mentioned, so we don't have paralysis. Any proximal long bone fractures, we don't have any of those, so we don't have 2 or more. And then we don't have amputations. So no. And then we get into this mechanism of injury criteria. Again, which we know is less. It's like 60%, 50 or 60%, depending on what the details predictive. So it's basically when you use mechanism of injury to determine injury, you've got a 50-50 chance, essentially. So you might as well flip a coin. But anyway, adults greater than 20 feet, the typical one story is equal to about 10 feet. Children greater than 10 feet or 2 to 3 times the height of the child. High-risk auto crashes. Death in the same passenger compartment? No. Intrusion greater than 12 inches on the occupant side? No. We said 6 inches. No ejection. And then vehicle telemetry data consistent with high-risk injury. So we're talking about what, OnStar, those sorts of things, or other black boxes you may have in vehicles, and basically all new vehicles do. And then auto versus pedestrian or bicycle or whatever with significant impact. So greater than 20 miles an hour. Nope, not here. Motorcycle crash greater than 20 miles an hour. No. So no, 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 no. Special patient or system consideration. So age, are they greater than 55? Children. Any other regional point of entry protocols or anticoagulation and bleeding disorder or burns? No, no, no. Time sensitive extremity, no. Pregnancy, no. Right down there at the bottom, EMS provider judgment. So in your judgment, do they have an issue? They have a concerning issue, but it's not an issue like chest tubes. You know, some flight services do those along with blood products. So, yeah, it's concerning, right? We're concerned about this patient, but they're not necessarily a supercritical trauma patient. So internal trauma criteria at Bay State Medical Center. Hopefully we're going to just align with, I'm not sure why we don't just align with the state criteria, because I think the state criteria is very reasonable. But anyway, this is our internal trauma criteria, so you know what or why you're going or not going to a certain area. And make no mistake, whether or not you go straight to the trauma bay, the trauma resources are still here, and they're just a phone call away. So trauma 1, trauma 2, that just means we're pulling people down from upstairs, we're dedicating OR rooms, prepping an OR suite, that sort of thing. It doesn't mean that if you don't have that, they're still going to be seen by trauma. It's just that they're not pulling trauma folks out of whatever they're doing currently. So if they're in a surgery, they're not going to just drop it and run, but they're still available if they need to. So systolic blood pressure less than 90, respiratory compromise, obstruction, or intubation. Blood transfusion, so if they're coming in by air or they're a transfer and they've got blood products on board. GSW to the central area, so the head, neck, torso. GCS less than or equal to 8 for adults or 12 for children less than 16 years old with traumatic mechanism. Paralysis, traumatic paralysis, ED discretion, so they're leaving it up to the ED provider as well to make that determination. So if they do that, that's their thing, it's on them. Major burns. Category 2, so those patients who don't have any category 1 criteria, but have 2 or more proximal long bone fractures, trauma or burns, multiple rib fractures, major soft tissue injury with stabilized bleeding. So, put a tourniquet on them, it's probably going to be Cat 2. Blunt abdominal trauma without hypotension. This patient was complaining of pain all over, mostly in my chest. I think you could argue that this patient has blunt abdominal trauma without hypotension, arguably. 2 or more organ system injuries, known traumatic brain injury or solid organ injury from transferring hospital. So if they've had a CT and they know they have a solid organ injury or a brain injury, traumatic brain injury. And then again, stab wounds to the neck or torso. Stab wounds, not necessarily lacerations. There is a difference. Category 2, continued mechanism of injury. So if they're ejected, death in the same passenger compartment, kind of the same for the state on those. And then pregnancy greater than or equal to 23 weeks, and that meets any of the above criteria. So I don't know why that's in there, because if they meet any of the above criteria, then they're a category 1 or category 2. So I think it was just an emphasis there that anyway, it's in there. So GCS, we get asked this all the time. I know it's annoying. I know it's of questionable value, but it's important for trending the patient's mental status. So GCS, it was originally designed for neuroassessments in an ICU, and I'm not sure that it's ever been really truly validated outside of that environment. We do know that nobody is good at accurate GCS assessment. When I say nobody, I mean EMS providers, nurses, and ED physicians. Nobody's good at it. Beyond that, the total number, so 15, 14, 13, 12, that doesn't really tell you a ton about the patient as a sum, right? So you could have, let's say, spontaneous eye opening, so 4, verbal response of 3, and a motor response of 6. So you got what now? 6, 7, 8, 9, 10, 11, 12, 13. That sounds kind of good, but it doesn't really tell you what's going on. So it doesn't tell you whether it's eye, verbal, or motor that is impaired. And so there's a lot of criticism of GCS, but bear with us. That's what has been decided by EMS powers that be for assessment of this. So just be prepared for GCS questions and be ready for those. I've thought about maybe making and laminating a bunch of GCS cards that you guys could keep with you, because I personally know that I'm going to be honest, I don't have the GCS memorized. I don't have it memorized. Aaron, do you have the GCS memorized? Do you have the GCS memorized? Yeah, Aaron doesn't either. I would ask Rick and Wook. Wook probably hasn't memorized, but none of the rest of us have it memorized. So, yeah, we've got room to grow. I've got room to grow. Moving on. So, the difference in the hospital between a Cat 1 and a Cat 2. So, in the hospital, this sort of describes what happens when we have a Cat 1 activation and a Cat 2 activation. So, Cat 1 reserves an OR and a CT scanner. So, as the patient clears a CT scanner, that CT scanner is reserved. Trauma surgeons immediately respond regardless of their current engagement. So they could have somebody cut wide open and they're going to drop that and run downstairs. Cat 2, nothing is reserved. Trauma finishes their current task and then responds. So we have, trauma residency. And so there are many trauma surgeons, 1 or 2 or more of which will be available in a pretty timely manner. Below those 2 is a trauma consult. So no matter what, whether or not the patient goes as a Cat 1 or Cat 2 to the trauma room, the resources are still available and can respond, and they will be seen as a trauma consult. So, it's just not as quite as high as of a priority, but the resources are there. So, I understand the frustration of prepping, trying to talk and prep your patient. Hey, we're going to do this. Oh, never mind. We're not going to do any of that. Forget all I said. I understand that frustration. Believe me, I understand it. Or of, not being particularly worried about it, and then all of a sudden everybody's calling a Cat 1, Cat 2. I had that happen. A patient was in a bit of a fight, and somebody caught him with a broken beer bottle right across the neck, and it just opened him right up, and it was very, very, very shallow, but it looked pretty impressive. But it was very shallow. There was no bleeding, at like nothing. It just kind of opened up everything, and it's where you could see all the cool stuff in his neck. And when I got to the hospital, they freaked out and said this is a penetrating trauma to the neck. And I was like, no, it's not. It was not penetrating. It was a sort of a slash. And the patient started freaking out, and I was a little frustrated. And of course, the trauma team, or trauma nurse rather, I shouldn't say the team, but the nurse got a bit of an attitude. And this was not here anywhere locally. So I get it. I get it. It can cause frustrations, and it especially causes frustrations here where there's a difference between internal and external. I get it, and I'm sorry. We're working to hopefully make it the same.
Chase at the base state. Chase at the base state.
Go ahead, base state time.
AMR 409, number 9, how do you copy?
Clear, go ahead.
We're about 5 out with a 22-year-old male, 6 complaints. So there's going to be a patient was involved in a motor vehicle accident this afternoon, approximately 20 minutes prior to our arrival. Patient was the unrestrained driver, rear passenger of a vehicle that was hit on the driver rear door by another vehicle, an unknown speed. We did notice some slight intrusion about 4 inches into the passenger compartment. Patient said she did hear his head, denies loss of consciousness, GPS of 1615 with no death. This was a thorough patient that we're oriented at this time. I have a C collar on him just as a precaution due to the mechanism of injury. Patient feeling some chest wall pain at the pain on the left side. He's with a 92% on room air, putting on some nasal cannula at 6 liters. He's now at 99% on the cannula at 6 liters. Other vital for 108 on 60, so 66. 20 to 24 respirations within the point of care right now. Lung sounds are slightly diminished on the left side. Any questions or comments?
Any ETOs?
Negative. Tonight, any drugs or alcohol tonight?
All right. So, no trauma activation. Patient was admitted to the ED with no initial trauma activation. Assessed by the ED, found to have crepitus and decreased breath sounds. Thoracic ultrasound was performed. No lung apical slide. So that means lung slide is you see a sign that's sort of sparkly on an ultrasound when the lung is up against the thoracic wall the way it's supposed to be. And if you don't see that, it means that, well, in this case, there's likely a pneumothorax. So chest x-ray was performed, large right pneumothorax, Cat 2 trauma activated, chest tube placed, been there, done that, that hurts. Anterior midclavicular line, pan CT, left pneumothorax, a right 1 through 3 rib fracture, pneumomediastinum, so air in the mediastinum, which can, of course, start to squeeze things in the mediastinum, which obviously not great when the heart is in that area. Non-displaced right sacral fracture, left superior ramus fracture, return to the trauma bay, and chest tube was placed. So you can see here this patient didn't go to the trauma bay, but they still have and had all of the resources there that were needed, and had a good. And this is a pretty banged up patient, so I think it's important to point that out. Some things were missed on the assessment, and that's okay. It happens. But it ended up okay. So anyhow, let's see. Here's a picture of it. Bilateral pneumothoraces, mediastinal emphysema. You can see kind of some free air there. And some emphysema here. And where else was it? There was another one in there. Anyhow, so and then here, of course, is the mediastinum, guys. So this is the ascending aorta. Here's the heart, kind of pushed down a little bit. Interesting. When I had a pneumothorax on my left side, I could feel my heart bumping against my lung. It felt super weird, but yeah, it's a thing. Bilateral chest tubes. You can see some more right here, some sub-Q emphysema here and here, and it looks like some here. You can see all this, I think. So there's the chest tubes, obviously here and here. You can feel those all the way into that. Yeah, that sucks. That's painful. So, great job by the BLS crew. Good assessment and documentation. They did a good job of predicting injuries from mechanism. Good call-in report. Reassess. Trauma patients can get worse. So, be aware of that. And keep in mind the statewide treatment protocol point of entry versus the Bay State internal criteria. Don't worry about the internal criteria. Like you do what you need to do to meet the statewide treatment protocol. And if Bay State does something internal, that's on trauma services. So don't worry too much about it. All right. So what I want you to do is get up, stretch, get some blood flowing, and walk around a little bit.
Sits alone by a lamppost, trying to find a thought that's escaped her mind. She says, "There's the one I love the most. This life's not far behind. She never lets me in, only tells me where she's been when she's had too much to drink. I say that I don't care, I just run my hands through her dark hair. Then I pray to God you gotta help me fly away and just let her cry. Tears fall down like rain. Let her sing. If it eases all her pain, let her go. Let her walk right out on me. And if the sun comes up tomorrow, let her be. Let her be. This morning I woke up alone, found her note standing by the phone. saying, maybe I'll be back someday. I wanted to look for you. You walked in, I didn't know just what I should do. So I sat back down and had a beer and felt sorry for myself, saying, let her cry. If the tears fall down like rain, let her sing. If it eases all her pain, let her go. Let her walk right out on me. And if the sun comes up tomorrow, let her rain. Let her rain. Tears fall down like rain. Let her sing. If it eases all her pain, let her go. Let her walk right out on me. And if the sun comes up tomorrow, let her be. Last night I tried to leave, cried so much I could not believe she was the same girl I fell in love with long ago. She went in the back to get high. I sat down on my couch and cried, yelling, oh mama, please help me. Won't you hold my hand and let her cry? If the tears fall down like rain, let her sing. If it eases all her pain, let her go. Let her walk right out on me. And if the sun comes up tomorrow, let her be. Let her cry. If the tears fall down like rain, let her sing. If it eases all her pain, let her go. Let her walk right out on me. And if the sun comes up tomorrow, let her be. Oh, let her be.
Just a young gun with a quick fuse. I was up
All right, we're back. Let's do this.
Just a
All right. Case number 3. You're dispatched for a well-being check. 81-year-old female apartment for a well-being check. You get on scene, and a police department reports that the families contacted them. They said they've been unable to reach the patient by phone for 2 days. Gained entry with Knoxbox keys. Patient was found in the bathroom. Reports she has been on the floor since Friday at 8 p.m., which is about 72 hours. So what are you immediately concerned about? Think about, differentials for a patient who's been on the floor for that long. So we're thinking rhabdomyolysis. That is my immediate concern. Right behind that, why did she fall? What was the initial fall, and why was she unable to get back up? So was it a spontaneous fracture that created the fall, or was it a fall due to trip or syncope or whatever, and then subsequent fracture causing them to be unable to get up? And beyond that, think about no food or water or meds for 72 hours. So somebody who is 80 years old or so, not taking, presumably they're on medications for 72 hours, potentially a lot of issues there. So patient states she went to use the bathroom and her legs gave out. All right. So she got weak, maybe. She admits her legs likely gave out due to having a few drinks. She sounds like an awesome grandma. Now, what other concerns does this add? Why did her legs suddenly give out? Why did she suddenly fall on the floor? Well, she says it might have been a few drinks. So did her legs give out because she was wobbly, because she had a few too many, or was it just coincidence? Or did she have more than just a few drinks? Always a possibility. This is true. This is me. My daughter got a pink Jeep, and my first car was a Jeep, and I was a bit jealous, so I decided to take it for a spin. She wasn't real happy. You can see her just kind of off screen on the bottom right corner there. Anyway, today's word is rhabdomyolysis. Oh my God, Rabder. You got the Rabder. So what's rhabdo? What is rhabdomyolysis? So rhabdomyolysis is the breakdown and destruction of striated muscle. Rhabdos, Greek for rod. Myo is muscle. Lysis is to break down, to destroy, right? So here's what we're looking at. You can see all the way down there at the bottom is the smallest group of striated muscle there. And as you break those things down, you get harmful buildup in the kidneys, and you can get acute kidney injury or even kidney failure. So a creatinine is a good way to estimate if that is likely to be an issue. So risk factors for rhabdo. So some people repeatedly get rhabdo. They're sort of at risk for it. And so there can be a metabolic disorder and a genetic component to it. You can also make it more likely through the use of alcohol, drugs, and other toxins. Those of you who do CrossFit, your colleagues know who you are. Believe me, we know who you are. Are at risk for rhabdo. Huge increase in cases of rhabdo when CrossFit became a thing. Ischemic injury, so vascular occlusion. So any type of essentially compartment syndrome or compression, or anything that kind of creates that anaerobic state can result in elevated creatinine, and if it's bad enough, you can get rhabdomyolysis. So Apparently, buffalo fish is a thing. I don't know. I'm not a huge fan of eel. I like sushi. I love sushi, but I've never really enjoyed eel. So anyway, not that that matters. So myoglobin, it is a binding protein, and it's very harmful to the kidneys. So again, a surrogate for impact to the kidneys is creatinine. So as those things go up, you're more concerned about kidney function. And so it's important to ask about kidney function. Look around. Have they soiled themselves? Have they been using the bathroom? Ask them. Potassium level can also be a concern. So 3.6 to 5.2 is normal. Patients was 4.7, so kind of in there in the normal range. Acidosis can be common, especially in crush injuries, especially as you release that. So you would expect to see if you had them on waveform capnography and you suddenly release or unpin them or increase blood flow to an area that was previously impeded, you should not be surprised to see a jump in exhaled CO2. So what are our treatments for rhabdo? What would you do? What are you going to do for this patient? So personally, one of the biggest things I like to do when I have a little old lady or old man or anybody really who's fallen and can't get up because they are in pain or they've broken something and can't stand, I start an IV and I begin pain treatment right then and there. I mean, the most painful part of this whole process is going to be you getting them up and moving them out to the ambulance through whatever mechanism you're doing that. But that's the most painful part. And I've worked with partners. I've worked with some awesome partners, and then I've worked with some partners who will sort of wait until you get to the ambulance to treat the pain. And at that point, you're kind of already past the most painful part. So if you're an EMT and you can't treat patients' pain, I get it. I know. I understand. I would love for nitrox to come back, and then we could use that for BLS pain management. But anyway, it's important to treat these patients' pain. You know, if you're a paramedic, be a paramedic. Use your paramedic abilities and deliver the most appropriate treatment to that patient that you can. Treat the patient and the patient's pain before you move them. I also like to use a scoop stretcher for these patients. I hate backboards. I've always hated backboards. I'm a big fan of scoop stretchers. Anyway, all right. So EMT, standing orders, routine patient care, right? So control hemorrhage, of course. Remove restrictive dressings or clothes or whatever. So do all that stuff. Fluid boluses can be important for these patients. Can be very important for these patients. So that's a big component of this. And then, of course, pain management. The exception principle of the protocols, always a favorite. It basically says, if you're not familiar, it says that there's no way we can write protocols for any conceivable case and or scenario. So good medical practice and the needs of the patient care may require deviations from these protocols. EMS personnel deviating from the protocols should take such actions as allowed by their training and in conjunction with their online medical control physician. So give us a call. The physicians downstairs really do enjoy talking on the radio. It's kind of a thing. And so don't hesitate to give them a call. And then, of course, you know, if you've got any, send us an email. You're like, hey, you know, I kind of did this and I called from med control. It's all good. But, you know, if you want, hey, just give us a heads up and we can take a look at it. And, you know, looks really good about empowering EMS providers to practice good medicine to the fullest extent possible. So, all right, rhabdo treatments. This is a 12 lead due to potentially electrolyte imbalances. So you may or may not see 12 lead changes due to electrolyte imbalances, and there's some discussion and controversy around that as far as how sensitive and or specific it is. 12 lead changes, that is, for electrolyte imbalances. It's controversial. So rhabdo treatments. It's essentially a result of acidosis, I'm going to say. So anaerobic metabolism, right? So we have sodium bicarb, and again, when you use this, you should expect to see a bump in exhaled CO2. So because of the effects of sodium bicarb, it binds with the hydrogen ions, combines with them, and forms water and CO2. So you should see a big bump in CO2 there. So let me get my little marker, handy dandy marker here. So you've got, right, sodium bicarb coming in here. I'm going to make a different color because this thing is red. I can make a different color. That's so cool. Okay. So you've got sodium bicarb coming in here, right? And it drops its sodium. Bicarb comes up here, combines, because this is what acidosis is. It's hydrogen ions, excessive hydrogen ions, who are damaging to it. We can get into the physiology of it, but anyway, we're just going to stick to this. So binds together, then forms H2O and CO2, and then you blow off the CO2 through the lungs. So that's sort of the quick and dirty there of sodium bicarb and how it works. So it doesn't really fix the problem. It just sort of helps your body more quickly eliminate some of the acidosis that is already in the bloodstream. The acidosis that is not in the bloodstream, it doesn't really affect. The acidosis that's not in the bloodstream in the cellular levels has an impact on the cardiac cells. And calcium is a great drug. It is pretty benign. In other words, it's a pretty big therapeutic window. So I'm a fan of calcium. I've used calcium quite a few times. And it's good for a number of different things, but in this case, we're looking at rhabdo. So helps with hyperkalemia. So if you've got a hyperkalemic or you suspect hyperkalemia, using your protocols and or consulting with Med Control, you should consider calcium for those cases. All right. So blood pressure is 142/92. Heart rate's 186. Heart rate is 186. 186. She's 80 years old. Respiratory rate 22. Satting 94% on room air. And good news, got a blood glucose level. It's 172. All right. So there's the EKG. Excuse me. So patient was found right lateral, no shortness of breath, no chest pain, no nausea, vomiting, no cough, no recent illnesses, complaining of body aches and weakness. I bet. Pain at a bump on the head from the original fall. So she fell, bumped her head. Right side edema. Right side edema, right? So she's laying on her right lateral recumbent. She's got right side edema. Various skin injuries to the right side, numbness and tingling on the right side, I bet. Edema around the eyes. She's kind of sick, right? Sick or not sick? I'm going with sick. So the pre-hospital treatments for this case: focused and detailed physical exam, stroke exam, good stroke exam. Really important. Just because you don't get called for a stroke alert doesn't mean you shouldn't do a stroke exam. And a stroke exam, remember, grip strength is not part of the stroke exam. Grip strength is not part of the stroke exam. Now, I use it to sort of get a gross estimate of motor strength, but it's not a good measurement of fine motor strength. That's why you have them close their eyes while they're holding their hands out in front of them, and you see little fine drifts, right? So it's very, very difficult and unreliable to try to estimate bilateral or unilateral strength from doing a grip test. So stroke exam, speech, facial, motor. Attempted the IV 3 times. That's a lot, but it happens. I've done it. It's one of those things. They ended up using ultrasound to get the IV in the hospital. So performed a 12 lead on the patient. Good news is she only had mild rhabdo. She did have acute renal failure, or we're now calling that, I think, AKI, acute kidney injury, because it's not always failure. She had a UTI, so it's good that they were able to find her. She was getting very sick. She was given fluid boluses and admitted for 4 days, and then discharged to a skilled nursing facility. So complex, very interesting case, very sick patient, but she was tough. She's tough, 80-year-old tough, and did really well. Pediatric altered mental status. All right, you're dispatched for a 12-year-old female at a local school. So what are the things that can cause altered mental status, particularly in a pediatric patient? All of these things. AEIOU tips. AEIOU tips. We'll go back to that. AEIOU tips. So, diabetic, adrenal issues, psychiatric issues, and medications. Dehydration, seizure disorder, trauma, stroke, hypoxia, developmental delay, overdose or underdose, infection or sepsis. All of these things, should be... when I think about I'm going to a call, particularly for something as vague as altered mental status, I generally cast a wide net for all cases, because I don't want to get what's called anchoring bias, and you can talk to Wilk about this. He's very big on avoiding that. You want to go where the evidence leads, and you don't want to accidentally make the case fit what you think it is. You want to cast a wide net, and so that way you're including all the potential causes, and you're not subconsciously excluding some causes, and then you miss something. We all do it. We're all human, but so that's why I try to cast a really wide net. I don't even try to, we'll just see what happens when we get there. I don't know. I know a lot of folks like to think on the way to the call, I had FTOs when I was new. What do you think it is? I'm like, altered mental status. I don't know. I mean, who knows? It could be one of a million different things. Well, which one do you think it probably is? I'm like, I have no idea. I don't even want to do it. I don't want to. We'll figure it out when we get there. History of the present illness for this patient: was playing soccer. They got on the bus after the game and began to say they didn't feel well. Sudden onset of vague diffuse headache, left-sided numbness. Interesting. Quickly became lethargic and unable to walk with slurred speech. All right, so stroke exam, positive or negative? Yep. Nausea, vomiting. What are you guys thinking? What are we narrowing down now, right? So we're narrowing things down. All of these things that it could have been, we're starting to narrow them down. It looks like an upside down pyramid, right? Hopefully we get down to one or two different things. Hopefully one thing, but denied any trauma. Symptom onset was about 1 hour by the time we get here. Blood pressure is 128/80, heart rate's at 90, respiratory rate 18, 98% on room air. GCS is 15. Yeah, GCS is 15. So, okay. Conscious, alert, and oriented times 4. Now, lethargic, slurred speech. I don't know. Do we want to call it 15? I don't know. It's an interesting. It's so that you can see kind of when we're looking at these things, and when somebody else looks at these things, it's important how it's important to really kind of talk about things. And here we go. We're gonna scream our assessment documentation. The office, the division of pre-hospital and disaster medicine here at Bay State is divided on whether or not it's ideal to document in all caps. I feel pretty sure that it's not ideal, but I understand why it's done. So I understand, but anyway. Physical assessment, Pearl, lung sounds are clear. Patient had significant slurred speech to where EMS could barely understand the patient. The patient's extremities were overall weaker than what they should have been, both left and right side. However, right side appeared slightly more weak. So again, stroke exam, So what is a stroke exam? So let's do a stroke exam, and that's a very formalized, formatted way of quantifying weakness, especially unilateral weakness. So probably best to use a stroke exam here. I'm pretty quick to pull out the stroke exam, and of course document it. So differentials, what are we thinking? What do you want to do? What else do we want to know? Sample history, dad reports the following. She's mostly healthy, lack of oxygen during delivery. So when she was a baby and delivered, there was a bit of a hypoxic state maybe. Cardiac valve replacement at age 5 for congenital heart defect. Currently on acne medication, don't know what it's called. She doesn't have any allergies. So treatment for this patient was a stroke scale, 12 lead, which was non-diagnostic for STEMI. So non-diagnostic for STEMI, being new to the area, I wasn't used to hearing, I'm still not quite used to hearing just 12 leads non-diagnostic. I don't know. I mean, okay, it's negative for STEMI, but what is the rhythm? So IV times 2, Zofran 4 milligrams, pediatric stroke alert. Here's the 12 lead. See anything funky? Nothing jumps out at me.
CMed to basic for priority 2. CMed to basic for priority 2.
Base station.
So Raymar 47217 coming in with a priority 2. That's a 12-year-old female, 1-year-old female, possible stroke, cardiac passage.
Go ahead, Amber.
We are currently in route about 5 minutes out with a 12-year-old, that's 1-2-year-old female patient. She's complete is going to be a possible stroke. She was with her school at Forest Park. They were playing a soccer game. Maximum well time is going to be 3:10.
Great job with the last one, Will.
Complained of a sudden onset of a headache and right-sided weakness. Staff noticed that she had developed severe weakness, was unable to walk, in and out of consciousness for a little while with good speech. She's currently awake. Speech is still slurred for us, not really answering questions appropriately. We have bilateral IV access. Blood pressure is 128/80, heart rate 94, normal status on the monitor, status 98% on room air, respiration 18, blood sugar of 104, pupils are reactive, pearl. Any questions?
Amber, does she have any kind of history?
Father said she had open heart surgery when she was 5 years old. She had a valve replaced, as well as some loss of oxygen during birth. But other than that, she was a normal, healthy kid, completely functional, no deficits.
Receive.
All right. So I think that was a pretty good report, right? Got to the ED, hand over in the pediatric recess room, went straight to CT scan on the EMS stretcher. Good, good, good. I'm really happy to see that start happening more and more. In the ED, she had normal cranial nerve exam, decreased strength bilaterally, upper extremities. Stat head CT and CTA were performed. Normal, no ischemia. So she ends up being diagnosed with a migraine, and by discharge, she was completely back to baseline.
To that TV reporter, remember after the Grammys on Sunday in her live report, we couldn't understand what she was saying, and many people thought at first, including doctors, that she had a stroke of some sort on camera, but that did not turn out to be the case, and we do know what happened to her, and David Wright is here with all that. Good morning, David.
Good morning, Robin. It turns out it was a migraine headache, but this is one of those there but for the grace of God moments for any of us in TV news. A stumble on the air that was so awkward, people thought she was having a stroke.
Well, a very, very heavy debatation tonight. We had a very Darrison by, let's go to Terrace English for the bit, the head of the pit.
It was an on-air blunder that had people across the country wondering and worrying.
I was aware of, this isn't making sense.
But last night, Serene Branson was back on the air on KCBS talking about what happened.
I started to get a really bad headache. And I was starting to look at some of my notes. I started to think the words on the page are blurry. And I could notice that my thoughts were not forming the way they normally do. Let's go to Terrace English for the bit, the head of the pit. They sat me down on an area right by Staples, initially gave me some water and just, are you okay? Are you okay? And I still couldn't form words at that point. To be honest with you, I started crying right away because I was scared. I was embarrassed. I was terrified and confused what had just happened.
While experts originally speculated Branson may have had a stroke, Serene's doctors now say she was suffering from a migraine aura, the result of a serious form of headache.
The most common kind of aura is a visual aura, where patients get distortion of vision, flashing lights, wavy lines. But patients can also have language dysfunction where they have particular difficulty expressing themselves.
I think it's clear from watching it that I was not drunk or on drugs, as I heard, that was reported out there. That's clear.
Branson says she's feeling better and wants to raise awareness.
If I can at least let people know that I'm okay and talk about the issue and let people know that it is something serious, that it is a medical condition, well, a very, then that's what I'd like to do. Debatation tonight. We had a very
So medical mystery solved, and for this reporter, a happy ending at least.
Yeah, we were so happy to see her last night and doing so well. Thank you, Dave.
So luckily it was just a migraine for the reporter on air. Highly embarrassing, though, I'm sure. Pediatric ischemic strokes, lots of causes. Birth control, as I'm sure you all know, a large portion of elevated risk factors. Very common. I shouldn't say a large portion, but a very common increase in risk factor for ischemic strokes, particularly in younger people that don't have other comorbidities. Are things like medications, in particular birth control, that sort of thing. Smoking, of course, those are all problems. Congenital heart defects, just like with AFib, you can have malformations. So you can have a little pocket and this sort of stuff. And when I say a pocket, I mean like a little an alcove or whatever in the heart, an appendage, a little area where blood can collect and is not expelled and or moved. So you can have some clots that develop in there. And just like in older adults, when you have a clot that develops in AFib, it can travel. And when it does, it can become a problem for obviously the brain, the lungs, PE, heart attack, all sorts of things. Another big cause of pediatric altered mental status is infection. So meningitis, obviously, one of the big concerns. And when they get to the hospital, they're going to have a lumbar puncture, and for rule in or rule out of that. Chickenpox, hopefully you either have received the vaccine or you are already immune to it. I had it when I was younger. But these things can put you at higher risk because of narrowing of the cerebral vasculature. Sickle cell anemia. Sickle cell anemia is less common in this area. When I worked in Atlanta, we actually had at the hospital a sickle cell center, and so instead of going to the emergency department with our sickle cell patients, we would go to the sickle cell center. And one of the biggest things you'll see with these folks is lots of pain. I've always been very aggressive with pain management for these patients. They're always in quite a bit of pain, whether they act like they are or not, because they're used to it. So they're not. Sometimes I've seen sickle cell patients be very used to it, and so they're sort of stoic, and they're like, yeah, no, I'm good. But then if you ask them for a pain rating, they'll give you a pretty high pain rating, but they sort of are handling it well. So just because they're handling it well does not mean that you should not appropriately manage patients' pain. I'm very aggressive with my pain management of these patients. One of the big things, obviously, is in addition to pain management, is IV fluid, which can help with these patients. So, but in the case of pediatric altered mental status, they can cause stroke. So, another risk factor, just because of the clotting. So you have these. For those of you who are trying to remember exactly what sickle cell is, you have these funky cells that look like sort of half moon, crescent shaped. And these, I guess it looks more like a banana. Whatever. Anyway, you get the idea. You have a bunch of these cells that are misshapen, and they jam up. They're like a log jam in the blood vessel. And as blood vessels narrow, they tend to jam up, and they can cause clots and or just blockages. Of course, trauma and loss of blood associated with trauma can cause altered mental status. One, just due to volume loss, and two, as your body tries to compensate. Vessels narrow, all sorts of nasty bad things happen that can lead to altered mental status. I already kind of talked about this. Oral contraceptives are have a known thrombosis risk, and so clotting is increased, and even more so when smoking. So don't smoke and do birth control at the same time unless you want to have a stroke. That's all we've got, folks. Let us know how we did. Let us know what you liked, what you didn't like, what we can do better. And make sure that you go take the quiz at this link. There's a little assessment, a knowledge assessment, a celebration of knowledge, if you will, at the link here. And it'll grade it automatically. Everything is shuffled and all that sort of stuff. It needs to be done on your own. Make sure that you've signed the M&M roster with your approved